So we'll be talking about treatment experience patients. So first we start with a case study. Alexander, 50 years old man, diagnosed by HIV, was diagnosed in 1990, very experienced patient. CD4s were at that time 30. 7 years after, he had CMV retinitis, of course, stage 3, and a lot of hospitalizations, lot of experience with other diseases, infections. He had including syphilis, diarrhea, repeated respiratory infections, and polyneuropathy. So he started in 92 with AZT, but the problem in this patient was non-compliance. He didn't use the drugs regularly. Even other regimens were used, included PIs and finally integrase inhibitors. So during that period, resistance was proved, and because he was still HIV viremic, and told us that that the compliance will be better. So in September 16th, resistance test was provided, and there was complete resistance to NUCs, partial and only partial resistance to tenofovir and etravirine. For 2 integrase inhibitors, and no resistance was only from integrase inhibitor to dolutegravir and for PIs. So since October 2016, we decided to give him lopinavir and dolutegravir, and he is till now virologically suppressed. Even the CD4 to CD8 ratio is very low. CD4's count is pretty nice in comparison to the past. In February, we have to introduce anti-HBV drugs, but we didn't want to give him tenofovir because of partial resistance for NUCs, HIV virus for NUCs. So we started with entecavir. Because this is co-infectious Congress, I have to introduce co-infected patients. So many years after his HIV positivity, he was infected by HBV infection in March 16, and it was acute course infection, but he remained HBsAg positive. And as I mentioned when we started with entecavir, the viral load is going down. Next co-infection was HCV co-infection, but the time of acquisition was unclear. The last anti-HCV negativity was in 2011, so he was infected between 2011 and 2016, had pretty high viral load, millions and 10 millions, and the therapy, thanks by Liverpool, was easy, and thanks by the AA therapy, he started by sofosbuvir because he was lucky. He had genotype 1b and was on PIs. So maybe tomorrow we'll know the treatment was successful. And till now, and maybe tomorrow we'll know the result of SVR. Let's move to situation in the Czech Republic. In the Czech Republic, almost all antiretrovirals are available. That's no problem. The one tablet regimen in the Czech Republic is for use 45% of our patients, and from the point of view of the whole Czech Republic, 50% have integrase inhibitors. inhibitor and 20% PIs. These are data from our center. We care about 60% of HIV positive patients in Bulovka Hospital. And in our cohort, integrase inhibitors are used in 60% of patients. In our experience, patients from the point of HIV infection, we have not a lot of experiences or causes or reasons to switch therapy. The most common because of toxicity or viral suppression failure. Mostly we switch because of toxicity, because of insurance rules, healthcare insurance rules, and because of anti-HCV therapy. Here are data from our center from 25 patients which had HIV and HCV co-infection and were treated by DAAs, but 9 of them were treated still with first generation PIs and included interferon therapy, and only 16 till now were treated by interferon-free therapy. And the necessity to switch because of start DAA was in most patients. Here is it. In 72% of patients had changed the antiretroviral regimen before DAS therapy, and 44% changed after DAA therapy the antiretroviral regimen. Let's move to HCV infection, so-called experience. Jaroslava, 41 years old. The time was the HCV infection diagnosed in family history. The 2 members of family had died for liver cirrhosis. Liver cirrhosis in a pretty young age, and she had thyreopathy, and in the year 2006 was not treated for HCV infection because of thyreopathy and afraid of worsening the thyreopathy after interferon. So I have seen her for the first time in July 2009. And she was genotype 1B, clinically had liver cirrhosis, but biopsy was not provided at the time. And we started with Pegriba, but because of adverse event Bell's palsy, we had to finish it after 5 weeks. What happens next? In 3 months, she came to me that she is returning from oncology because she had lymphadenopathy and non-Hodgkin lymphoma was diagnosed. But of course, we couldn't do anything with the Hep C, only symptomatically. We treated 3 years after ascites. She started diuretic therapy. And in 2015, lymphoma relapsed, and in next year was her liver functions were worsening, but she was not included in the waiting list because of lymphoma, and she was a real candidate for DAA therapy, interferon-free therapy. So, what happened next? We asked repeatedly healthcare insurance to cover Harvoni for 6 months, but their answers were negative. I had to send them full text articles, but we didn't succeed. The reason why they didn't want to cover the treatment was because there are no experiences. Even I sent her papers with benefit of HCV clearance after therapy, benefit for lymphoma. So she died. So it was not experience. So now we have, we are in another situation, and in treatment experienced patients, we have a lot of combinations even for difficult to treat patients. And easily recommend in previously DAA treated patients RAS testing, but even in Polaris 1 and Polaris 2 study in treatment experienced patient with genotype 1, the SVR is very high, even in non-1 genotypes, and even in those who had confirmed baseline resistance. The other situation may be in countries where new drugs, Sofosbuvir and Voxeloprevir and Pibrentasvir are not available, and only Harvoni is available. In those countries, the test resistance makes sense because one Indian study confirmed that the difference maybe of SVRs is 97 to 80%. In the Czech Republic, all drugs since the 1st October now, all drugs are available. And I have data, not very recent, from the harm registry since January 16 to January 18. And at that time, 1,052 patients were treated by DAA. Here is the Prague Center. We treat only 3%, maybe because Prime Minister is really not my friend. We have no experience in our center in Bulovka with with DAA experience patients which failed. So the problem is money. Even we care not only for HCV co-infected, but also for mono-infected patients, and we cover 60% of all HIV positive patients from the Czech Republic. So how can we solve the situation? Thanks to, for example, Dr. Fraňková, Sonia, my colleagues helped me from other centers, so we treated by interferon-free therapy maybe half patients, the other half other colleagues from our centers, because they have better access to the covering the therapy, and still we have very large waiting list. Here are data from about treatment experienced patients from the same harm register and same period. 46 patients which start in the Czech Republic DAA therapy are treatment experienced, but only 1.6% of them were before treated by interferon-free regimen. So, because we have no experience, Sonia Fraňková was so polite and give me data from their experiences from Transplant Center Prague. And it's connecting the 19 patients which failed the interferon-free regimens, some of them after daclatasvir asunaprevir, which was in our so-called special program, some of Harvoni, some after 3D. Most of them are on the Sofosbuvir VOX regimen, but the results are still not available, and the other which which were on another regimen. In these other patients, we still not. They succeeded as we are. Because I have no experience, even no experience about the situation from Central Eastern countries, so I was so rude, and I asked some colleagues from CEE countries to fill the questionnaire I provided. So, questionnaire connecting the access to DAA therapy in Central and Eastern European countries. So, the main problem seems to these experts, of course, it's a subjective RAS testing. The coverage of a label regimens is the second problem. Drug price is not now the first problem. Missing drugs on the market only in some countries, and of course, high percentage of treatment failure is no problem. As conclusion, switch of art is common in people starting DAA therapy. Redistribution of sources in the Czech Republic for DAA covering of DAA treatment is necessary. 46% of DAA therapies are in experienced patients, and that's all. I thank my colleague from CA countries, my colleague from AIDS Center, Sonja Fraňková and Petr Urbánek for data.